Okay. All right, we're all set. So welcome to the next comparative ocular pathology rounds. And without further ado, let's get right to it. So this is a case of you'd think as I was here, I would have had these all prepared, but all right, Marvin Gray. A 10-year-old neutered male Sharpei. We got the right globe from Marvin Gray. It was ophthalmic with corneal fibrosis, and they were unable to see inside the eye very well. But on ultrasound, they saw retinal detachment with fibrovascular membranes suspected, but they said cannot rule out neoplasia. And I think that we can't either based on this gross image. As always, we have a hemisected globe with the cornea at the top. We have both halves in this case. You can see one half does not have the optic nerve, and here's the one that does. This is the lens here. It looks like a quail's egg or something like that, very opaque and white. So there's definitely a really severe cataract here. But the main thing to draw your attention to is that what may be retina here is sort of detached, torn, very distorted, thickened, and kind of opaque and tan. It should be like a nice delicate layer of tissue paper against the back of the eye. We also have some thickening of the uvea and pretty severe distortion there as well. It's hard to make out anything that you could easily call an iris leaflet or a ciliary body here. It's all very distorted. You can certainly also see briefly that opaque cornea that would have caused issues with their intraocular exam clinically. All right, so let's take a look at the histo. Let's go screen on that. All right. So we have many sections of this globe, but I'll show you the one that has the most optic nerve. We'll start with the subgross. Actually, we'll make sure we turn it the same way each time. So here we have this very densely cellular infiltrate in the anterior uvea. It's forming this sort of network of membranes that cross the vitreal space. It's lining the choroidal surface, and then it's hard to make out anything that's clearly retina here. I'll prove to you in a hot second that this is retina, basically, but there's also this densely cellular infiltrate in the central retina and extending into this deeply cupped and atrophied optic nerve, which has sprouted some handy dots for margin measurement. We also have, from low magnification, a suggestion that this is going to be a cataract, but it's a relatively minor thing, and some vascularization in the cornea, or at least something cellular up here on the subgross already. But that cellular infiltrate is the main thing that I want to show you today. Let me see if I flipped it around the wrong way now, though. I did. Let's keep it the same way around so that it's easier to follow. It is as low as I can go. All right, so here is a closer view. Let's start with the cells of interest. All right. So this is a very densely cellular neoplasm, and it's not really forming any distinct organizational structures per se. Sometimes it forms sort of poorly distinct rows in here, though, and it very frequently can be found palisading around blood vessels. Not that one, though, because that would make it too easy. We'll go further to the back for that phenomenon. These cells are spindle to sometimes sort of carrot-shaped with one tapered end. Here, at least, is some degree of palisading. You can see that there. Cells are kind of forming like a poorly distinct row where they're lining up. You can see that this is peppered with melanin-laden cells, which represent pre-existing melanocytes. I'm going to put that more in the middle. Keep walking. We can see that they're still lining the choroidal surface like we saw from subgross. And as we keep walking back, what I really want to show you is the retina and optic nerve. There we go. So here they are. They're kind of palisading around these empty cyst-like spaces. They sometimes palisade around blood vessels. And those spindle to kind of carrot-shaped cells are what we're looking at here. I did not. I did not have the condenser in. Thank you for pointing out. Here we go. We'll do that again with the condenser in because it looks nicer. There we go. We'll give you another closer look even too. All those cells. The only other thing to really show you apart from this very poorly differentiated neoplasm is this detached, multifocally torn retina, which is very severely atrophied and often quite necrotic. We can make out here, for example, that we have recognizable retina, which is basically just down to like a glial scar at this point, and then it kind of progresses into eosinophilic cellular necrotic debris. So detached, torn, atrophied, necrotic retina. This was thoroughly a blind eye. So this is a very interesting, poorly differentiated neoplasm. We're mostly going to focus on the neoplasm. I think you guys have seen cataracts and corneal disease before. We call this a primitive neuroectodermal tumor. Which there is a push to rename this in veterinary literature as well to neuroectodermal embryonic tumor. So originally called PNET, primitive neuroectodermal tumor, pushed to move it to NEAT, or neuroectodermal tumor embryonic origin, or neuroectodermal embryonic tumor. The reason being that in human medicine, they have a lot of molecular markers for these to get kind of really specific about the sorts of origins and things like that. And they've renamed it in the WHO classification based on that. We don't really have those molecular markers in animals, but there's a push to follow suit and rename it to NEAT. But whatever you want to call it, it is a poorly differentiated tumor that is thought to arise from very early kind of primitive neuroectodermal cells of origin. We don't have very many of these even in the Coplow database, and the biologic behavior of this is still fairly unknown. So a very interesting case. This animal's tumor was completely excised, which was nice. We can go back to that optic nerve and I'll show you that again. This is our nice deepest section of the optic nerve, and we still don't quite have their cut end where they cut the nerve surgically, but there's plenty of normal optic nerve parenchyma between this tumor and the brain. All right. That's this case. We'll show you the diagnoses. There you are. And just some other more minor things along with that tumor.
What was the dog name?
This was a 10-year-old dog. Yeah. It's interesting. This is a kind of a net that includes the retinoblastomas and the medulla epitheliomas and things like that. So, but this is a somewhat older dog. All right. That's it for this one. The first three are going to be tumor day today. So we're going to hint you with that and move on. We have Brooke Lynn, which is 2 words, a 5-year, 6-month-old basset hound. So this dog, they describe an optic neuritis of 3-week duration with severe papilledema to ONH with a mass-like effect where the ONH is 5 times larger than the normal optic disc. They also described a large retinal hole temporal to the ONH, and although we cut this horizontally, we didn't necessarily catch that, but that was an interesting description as well. So here is our gross view, and you can see that the anterior chamber is relatively quiet. In the back, though, we have this mass effect that they were describing clinically. So this is where the optic disc should be. It is usually relatively flush with the back of the eye. In dogs, they have a lot of myelin, so it may pooch out a little, but there's certainly not this much. We have this sort of tan white mass that is bulging into the vitreal chamber. And we have this lovely little flower of intravitreal hemorrhage, or it also kind of reminds me of those octopi you can make out of hot dogs. I don't know if I'm the only one that is reminded of that there, but it's a very scientific description, you see. All right, So let's take a look at this tumor histologically. Suppose we'll start with the subgross and we'll go. All right. Yeah. All right, so here's our globe. The section that captures the most optic nerve is missing its cornea, but we have the cornea in another section. I'm just going to show you this one though, because it's best for the tumor itself, which is our most important thing to look at. So we have this highly cellular neoplasm that is infiltrating pretty much the entire optic nerve in our examined section on this globe. And it extends into the central retina and bulges into the eye to create that little mass effect that we were seeing both clinically and grossly. Let's take a look. Flip it around again because we want to maintain orientation. Here we are. In the condenser. So these neoplastic cells are kind of polygonal or rounded, polygonal, basically round. They have maybe a mild to moderate pleomorphism. There are a large number of mitotic figures. You can see a good number popping in already. They sometimes have a somewhat foamier cytoplasm, but otherwise it's hard to tell specifics on them. And there are a good number. Wow. Sorry for moving so fast. It's such a high magnification. Here we go. Of these areas that present with cells directly lining cyst-like spaces full of a sort of mucinous material. So those are some key features of this tumor. We didn't see any glomeruloid vasculature, which is another feature we might look for a tumor like this. But the diagnosis is here. And we do also have this lovely section of that intravitreal hemorrhage coming in just a little bit there. Another key feature to point out in a tumor like this tumor is basically destroying the optic nerve. And so if you check out the retina, there are no ganglion cells here really to speak of. Keep going just a little ways and show you that off. So basically those axons are gone and the cell bodies are kind of following suit. So no more ganglion cells, commonly seen in cases where the optic nerve is compressed or distorted or invaded in some way, just like this one. So this is an optic nerve glioma. We typically don't classify these any further.
Take it out.
Oh,
Show
sorry,
that,
go ahead.
nice area of interaction of the tumor with the retina there.
With the retina.
See how it glands with it.
That is a good point. So you can make out here this very distinguishable outer nuclear layer.
Yes, if you go north, you can actually walk from the normal retina into that area. Or relatively normal. Non-neoplastic retina, let's put that.
So yeah, we still have some maybe kind of unusual looking cells here, but there's at least recognizable layers of retina. And as you walk further, those neoplastic cells are in the nerve fiber layer, kind of now admixing with the internuclear layer. And then it just disappears into this tumor. Yeah, that is a good thing to show. The other thing I'll show you is we have the brainwards side of the optic nerve sampled separately here. And it was hard to assure complete margins in this case because this optic nerve is basically completely atrophied and fibrotic. And there are a couple of large cells that are similar in morphology to neoplastic cells, which are maybe more likely reactive glial cells, but it's hard to tell based on just morphologic features alone. Either way, I wanted to show off how severely affected this optic nerve is and how distant the effects have extended from the main mass of the tumor. There's also a lot of hemosiderin-laden macrophages in this nerve, indicating chronic hemorrhage. So that's the last thing I wanted to show. We typically don't classify optic nerve gliomas more specifically. Sometimes there are some that by cell morphology look much more like oligodendrogliomas. But typically you need all sorts of special markers to be sure of the specific glial cell of origin. And at least based on histopath alone, H&E alone, I should say, we'll leave it at glioma, which we did in this case. So that is this guy. There isn't really much else that I wanted to show you, so we will go back to the PowerPoint.
Talked about the prognostic feature of optic nerve. The main prognostic features being a clean optic nerve.
Yes, we should add that the main prognostic feature of retinal gliomas is whether it is completely excised. So extension towards the brain along the optic nerve would suggest a more poor prognosis. But yes, in this case, it was hard to assure complete margins. So we'll hope that Brooklyn does well, though. Right. And there you have it. I always feel like I should pause at this point to ask for any questions, but that's not how this is working. So ask any questions you would like in the chat, and we will go ahead and continue. All right, so the last case that I will show you before switching to my esteemed colleague Gillian Shaw is this one. So this is a case of Harry, a 13-year-old neutered male domestic short-haired cat. And what they describe in Harry is buphalmus, fibrin in the anterior chamber, and a stromal ulcer in the cornea. And when we have the benefit of sectioning the eye completely in half and looking at it on the cut section, we see a little bit more. So we do have a complete full thickness defect through the globe, completely through the sclera and all the tissues around the globe here. There were also some other iatrogenic defects that were acquired during enucleation. So this may represent a real rupture, but we suspect it may also be have been an intraoperative happenstance. The main thing to point out, apart from that, though, is how severely thickened this entire uveal tract is. Very thickened, white tan. You can see kind of the posterior pigmented epithelium on the iris here, but the rest of the iris is just all of this, basically a tumor. Spoilers. I already said we were going to have neoplasia for the first three. We also have a similar effect, expanding the sclera and episcleral tissues and probably sending it a little bit into the conjunctival substantia propria here. So a pretty extensive tumor in this globe. We do not have an optic nerve head to show you on this one, but I don't think we'll need it to see the key features. Oh, keep famming this together. All right. Switch this. There and right there. All right. So here's your subgross. It pretty much looks like what you might expect. There is a very densely cellular infiltrate, or there's very dense cellular infiltrate. There we go. In the uvea, extending into the sclera, extending into the episcleral tissues. Everything that we saw on the gross, here it is in the bulbar conjunctiva as well. We do have kind of an awkward sampling of the lens here and a little bit of retina, but like I said, no optic nerve in this case, just because of a little bit of distortion. And then here is that gap, which we wondered if it could have been a rupture. Sometimes neoplasia that is particularly aggressive and invasive in the globe will invade through the globe and create enough of a sort of instability, particularly if it gets necrotic after that, to create a rupture of the globe. It's also possible that this was an intraoperative thing. So move from that to showing you this tumor. I want to show you the other side. There we go. So this neoplasm is composed of sheets of round cells. I'm actually going to keep going into one of the even more dense areas over here. You can see that they're invading between pre-existing scleral collagen. They're supported often by pre-existing stroma. They have a relatively monotypic appearance, although there's a lot of nuclear atypia going on here, kind of slightly abnormal potato-like nuclei, kind of lumpy bumpy. There's coarsely clumped chromatin. Most of these nuclei were greater than 1.5 erythrocyte widths in diameter, so they were fairly large. Actually, we do have an erythrocyte over here to compare. So if you can kind of compare the width of that to the neoplastic nuclei, often about 1.5 widths or slightly greater. This is a lymphoma. We'll go ahead and give that away right away. And you can see how extensively invasive it is. Oftentimes, neoplastic cells in the globe will extend around the vessels of the scleral venous plexus and the collecting ducts, which represents kind of a path of least resistance for them. These guys are perivascular, as it turned out, but very invasive, very distorting neoplastic process in this globe. Just kind of showing you the whole picture here. There was also retinal detachment as we pass the retina here, and a pretty severe retinal atrophy to be expected with how distorted and thickened this choroid is. All right, another feature that actually is probably worth showing before I switch to our IHC, which we do have in this case. You can see that all of these neoplastic cells also have a liking for the epithelium. So we can make out the pigmented ciliary body epithelium much better because it has that melanin in it. And you can barely make out where the non-pigmented epithelium would have even been because it's just so infiltrated and invaded by neoplastic cells here, which is a feature that lymphomas can sometimes do. All right, let's switch to the IHC. So we did offer IHC to phenotype these, and they took us up on that. And there was kind of a slight surprise because a lot of the larger cells in cats will often be, actually, let's start with this. A lot of the larger cell lymphomas in cats will often be B cell. In this case, this is our CD20. And we do have scattered cells that are strongly labeling, but oftentimes they're scattered or they're forming these clusters that may have been kind of pre-existing lymphocytic follicles or something along those lines. Let me see if I can hit the exact spot that I really wanted to hit before. It was close to the edge of the rupture. And you can see that all of these cells that are forming the sheets, and oftentimes the ones that are larger and have more of the nuclear atypia, and if I get lucky and hit the field that I wanted, the ones that have mitotic figures in them, maybe that one, it's hard to tell on the camera. But you can also take my word for it. The ones that had the mitotic figures in them were negative. So when we did the CD3, by comparison, look at all of that labeling. This turned out to be a T-cell lymphoma. So uveal T-cell lymphoma in a cat. I'll transfer back to the PowerPoint. Oops, I didn't want to do that. I want to do that. There we go. And there was a study that came out in 2020, and a similar study has also been done in dogs, so both dogs and cats, that basically described that a good percentage, I actually have the percentage right in front of me, 64% of patients with uveal ocular lymphomas are free of systemic disease at the time of enucleation. And these have been termed presumed solitary ocular lymphoma, or PSOL. So some of these patients may not actually have systemic lymphoma that is localized to the eye, although that can also happen. They may actually have lymphoma that has arisen in the ocular tissue and may not have disseminated yet. And those patients that do have primary ocular lymphoma that has not disseminated yet, as you might expect, have a better prognosis. Generally speaking, that's not something that we can tell for them histologically, and staging of the animal is likely indicated to be sure how the rest of the body may or may not be involved. This one was also incompletely excised, though, with that invasion into the episcleral tissue and things like that. It did reach our examined margins.
There was nothing in the history, right, that suggested systemic disease.
No, at bare minimum, they left the general medical conditions section blank. They do note ocular hypertension in the other eye, but we have no idea what could be causing that. So, yeah. Hopefully it's a primary for this kitty. I'm rooting for you, Harry. That's it. I will hand the floor over to Gillian.
Alrighty. Oops, no, I didn't want that. All right. First up for me is a 14-year-old paint horse mare named Callie. She came with a history of severe blepharospasm, anophthalmos, profuse mucopurulent discharge, minimal view of globe, but suspect profound uveal prolapse / chronic corneal perforation. In January of 2022, about 9 months ago, sustained a corneal ulcer that was treated with neopolybac, did not appear to improve. The eye continued to worsen. The RDVM suspected retrobulbar tumor. Horse has been persistently uncomfortable. No retrobulbar disease noted during enucleation. So here is the globe as we received it. And you can kind of appreciate that the sclera is a little bit wrinkled. And also, if you're familiar with the size of horse globes, this is a 1 centimeter marker down here. This is actually a very small, distorted horse globe. So right off the bat, we would want to call this thesical. In addition to that, the cornea is difficult to make out. I can tell you that this is the posterior sclera back here, and that this is the artist formerly known as the cornea. And it has been effaced by this off-white tissue. It's opaque as well. There might be a little bit of corneal stroma remaining here. No lens is visible in this eye, and the vitreous is a solid yellowish gel with these like tan strings running through it. The suprachoroidal space is expanded by edema, probably because of previous corneal perforation and loss of intraocular pressure. So we will go ahead and go to our slide now. We actually have this case on 2 different slides because of the difficulty in sectioning it. And also, unfortunately, the large slide here has unfortunate sectioning artifact. So we'll keep that in mind. Okay. So here is the anterior part of the globe. This is a tumor. I'm just going to go right there. Here is the posterior aspect of the globe. The optic nerve is actually on a different section, which I will show in a moment. And pretty much everything in the globe is fairly effaced by a cellular infiltrate of one sort or another. So we're going to start right here. So from a relatively low magnification, hopefully you can start to make out that a lot of these neoplastic cells are forming some sort of structure or another. Some cords, some trabeculae, some lobules. And this is characteristic of epithelial neoplastic cells. When we go higher mag, the cells are polygonal with indistinct cell borders, eosinophilic cytoplasm, round to oval nuclei with some coarsely clumped chromatin and single fairly prominent large nucleoli. There's also a very decent mitotic rate. Here's a couple of mitotic figures to prove that. And then in some areas, when we get closer to the surface of this neoplasm, the cells are larger and they have more abundant eosinophilic cytoplasm, which is characteristic of squamous differentiation. So not surprising, we have a paint horse who is no doubt poorly pigmented around the eye, lives somewhere perhaps where sunshine is a problem, and has developed an ocular surface squamous cell carcinoma. Sadly for this eye, it has been going on for quite a while, and it has extended right into the globe and effaced the interior of the globe. In some areas, so here's, once again, we have quite a bit of sectioning artifact here. But here the cells are even more convincingly sort of forming these cords and trabeculae that I mentioned. And so there's that. Also, unfortunately, this has been a chronic corneal perforation, and a lot of the cellular material that's inside the globe is actually suppurative inflammation, i.e. dead neutrophils and viable neutrophils, a lot of fibrin, and there's also a lot of bacterial colonies in here. So this horse has been living with bacterial endophthalmitis for who knows how long, which is pretty sad, but these are all gigantic bacterial colonies. So there we go. And I'll just show you the slide with the optic nerve on it, because it was a much nicer section without all the artifact. So here's the optic nerve. Here's the end of the optic nerve. As we move into the globe, here's more of that suppurative exudate with a lot of shmoo and also bacterial colonies. And then as we move up into the anterior uvea, you can see how that neoplasm has just extended into the sclera and effaced the anterior uvea in this section. So there we go. And we never found any trace of the lens. So we presume that it was extruded. So we have an extensive ocular surface squamous cell carcinoma with intraocular extension. There were clean margins as far as we could tell, which is good news. Severe fibrinosuppurative endophthalmitis with intraocular bacteria, presumed aphakia, and presumed diffuse retinal detachment and necrosis. We never found any evidence actually of the retina. So that is the story of Callie. All right, next up is Ivy. Ivy is a 2-year-old spayed female dachshund from the upper Midwest. She came with a 2+ week history of corneal vascularization, posterior synechia with iris bombay, 3+ flare, corneal edema, diffuse retinal haze, ophthalmic, and blind. The submitting clinician had a concern for possible infection or foreign body as the cause of the uveitis. Suspect secondary glaucoma due to ophthalmos. However, the IOP was only 6 at the time. And there was also concern for retinal detachment. Apparently, the dog also had a history of a recent camping trip prior to the eye issues. So that was kind of interesting. So here's our globe. As usual, cornea is at the top, the optic nerve is at the bottom. I grossed this one, and this is the ventral aspect of the globe. And all of these extraocular tissues were very tightly adherent, so I left them all attached in situ when I hemisected it and when we sent it for processing. What we can see, the anterior chamber contains this sort of gelatinous, sort of opaque gel. There's that same material in the posterior chamber right here and here. You can see how the iris is sort of thin, and its little pupillary margin is attached to the lens. So that is good for the posterior synechia that the clinician described. The lens is, at least in the proper position, it's hard to tell whether there's a cataract at this magnification. The retina is indeed detached. So here's part of it, at least here. And then I think this is vitreous and not subretinal space, but I could be wrong. But anyway, there's a similar sort of gelatinous solid material in this area, which is either subretinal space over here for sure, and this might be vitreous. There's also some more opaque material lined up along this posterior aspect of the eye. And then over here in the ventral sclera, there's actually a defect, which we did manage to capture in section. And there's also some exudate here. It's a little bit orangey yellowish there. And there's some hemorrhage in these extraocular tissues. And the extraocular tissues themselves are sort of off-white and very solid looking. So now we will go to the slide. maybe. Oh, helps do this. Okay, there we go. Okay, so oops, right. Let's have only one arrow. Competing arrows is annoying. Okay, so right here is that ventral sclera that I pointed out, and there is this linear tract right through it with a lot of purple stuff in it, which I'll tell you right now is inflammatory cells. Also, the extraocular tissues around there are also a little bit more basophilic than they should be. So there's a lot of inflammatory cells in those extraocular tissues as well. That gelatinous material that we noted grossly is present as this homogeneous eosinophilic material, which is essentially intraocular fluid with a lot of protein in it. Here is the detached retina. So yeah, it was only detached on that. Well, it's detached everywhere, but low-lying detachment elsewhere. But anyway, more obvious detachment here with subretinal stuff, exudate, protein, etc. The lens actually, I think, was fairly normal in this case. And here's the more low-lying retinal detachment with exudate in the subretinal space. The optic nerve head was not terribly well sampled here, but there is inflammation in the optic nerve itself and around the optic nerve. So we'll start with the cornea. And there are quite a few blood vessels in the peripheral corneal stroma. So there is peripheral corneal stromal vascularization. There's that proteinaceous material in the anterior chamber. And there's a few red blood cells and a few neutrophils, some of which are mingling with that corneal endothelium there. There is a pre-iridal fibrovascular membrane here that helps to explain the posterior synechia and iris bombay, which is not very well sampled on this slide, I don't think. Yeah, but we saw it grossly. And as we take the tour around the eye, we start to see that there's a little bit more inflammation, sort of mingling with the iridociliary epithelium there on the ciliary body, and also occupying the vitreal space. Some red blood cells, and a bunch of neutrophils and some macrophages. Macrophages, neutrophils, red blood cells. Okay, so let's go look at that ventral scleral defect. So just this alone is pretty good for a penetrating trauma of some sort. We have this nice full thickness linear tract right through the sclera and through the uvea, which I think is choroid at this point. And when we go closer, it is composed, this inflammatory infiltrate is composed mostly of neutrophils with a few macrophages. And then we have this little friend here. So that is a yeast. The size is fairly consistent with blastomyces species. This one doesn't have nuclear material. I'm not entirely sure why this individual does not have nuclear material, but there are others scattered around. So in this field, we have these larger cells. These are the macrophages, and then a bunch of neutrophils. So we have essentially pyogranulomatous inflammation that is occupying this defect. And as we scan around, we do find more of these yeast. That one was sort of in the defect itself, or just outside of the defect in the extraorbital tissue, or extraocular tissues rather. And then when we head into the globe, we can see that that inflammation is similar inside the globe, and that we also have yeasty beasties inside the globe. This one right here. So we have a dog from the upper Midwest who was on a recent camping trip, seems to have some sort of defect in the eye that is most consistent with a penetrating trauma. and also has blastomyces inside the eye. So that's a little bit of an interesting set of lesions in this eye. You can go take a look at the detached retina on this side. So I think there was pretty extensive retinal necrosis as well, but there's the subretinal exudate. There's the detached retina. There are multifocal fibrin accumulations in the retina, so some vascular leakage, probably associated with the inflammation. And then the retina starts to lose all nuclear detail here, or nuclear layering, and has this more homogeneous eosinophilic look to it, which is consistent with necrosis. When the retina undergoes necrosis, one of the last holdouts that are visible histologically are the blood vessels. So you can see that those blood-filled vessels are still nicely visible. So sometimes all we see when a retina has undergone necrosis are those blood vessels. So there is IVs. There are IVs lesions. I'm not sure. So we had a ventral focal scleral perforation with severe fibrinoseprative necrotizing and histiocytic panophthalmitis and orbital cellulitis with intraocular, intraorbital, and optic nerve yeast consistent with blastomyces species. Most likely it's dermatitis, but that's impossible to tell on histology. There are also the preorbital fibrovascular and pupillary cellular membranes with posterior synechia. We actually examined multiple sections of this eye to get all of these diagnoses. Complete retinal detachment and multifocal necrosis and glaucoma as from history, which was secondary. So this was interesting. Just the fact that the dog was in the upper Midwest is not surprising that it has blastomycosis, unfortunately. But this penetrating trauma is an interesting feature, and we're not sure. So I did inquire in my comment to the clinician whether any systemic signs had been noted in this dog. They didn't mention anything in their submission form, but maybe now they've gone on to maybe check out the lungs, pulmonary or thoracic radiographs, or do a urine antigen test. So it is really interesting to think about, like, did this dog have blastomycosis to begin with and was blind and then traumatized its eye? Or was this actually a penetrating contaminated trauma that had blasto in it, that implanted blasto right into the eye? I find that less likely, but we do toss that around occasionally when we see these cases. So yeah, I haven't gotten any follow-up on this one to find out if IV actually has systemic blasto.
Alternatively, but I guess also less likely would be that that's kind of a fistula strap from an endophthalmitis rather than penetrating trauma. But it's interesting because it's so well delineated and so well demarcated, and
Yeah,
it does look like a penetrating trauma.
yeah. I didn't find any bacteria in the eye. And often with contaminated penetrating trauma, we would find bacteria. So yeah, good question. I don't know. Anyway, that is IB. Next up is Enzo, who is a 9-year-old neutered male boxer. Enzo came with a history of moderate blepharospasm, normal eyelids, 1+ gray mucoid discharge, diffuse corneal edema, axial 5 millimeter superficial corneal ulcer with loose epithelial layers, trace flare, mydriatic pupil, unable to visualize the details of the lens, hazy view of fundus, a pink outline of the optic nerve head was visualized. Gonioscopy of the other eye revealed a closed angle. They did not mention glaucoma in the other eye. So this eye did have glaucoma. Its IOP was 30. So when we got this eye, the cornea was a little bit cloudy. Here's a hemisected, slightly tilted view to make sure that we could see the fundus really well, and it also highlights the cornea. This might just be some adherent hemorrhage on the corneal surface, but there is also an ulcer. The lens is fairly boring. So is the anterior uvea, at least grossly. The back of the eye, however, is not boring. So there's a lot of this sort of tan vitreal strings that are sort of closely associated with the retinal surface. The optic nerve itself was ill-defined grossly. So normally a dog optic nerve is this sort of off-white structure that sort of projects up into the vitreal cavity ever so slightly. That's due to the myelination of the optic nerve head. But it was ill-defined here. And I also grossed this one. I said the tissue around the optic nerve seemed very thick. And then I noted those strands within the vitreous. So let's jump into the histology. So right there, you can see the corneal ulcer, and you can actually see those loose epithelial edges here. So that is pretty good for an indolent ulcer, which we'll take a look at because it's a nice example of what an indolent ulcer looks like. The iridocorneal angle is open. The cleft is not so open. Same on this side. So I think there's a epiphyseal of some sort causing peripheral anterior synechia. The lens is boring, as I said. And then when we get back to the back of the eye, it gets pretty interesting. So we have this sort of pale purple material adherent to the retina, the inner retinal surface. And it's also forming these strands in the vitreous that are also closely associated with the, posterior vitreous or retinal surface, optic nerve surface. When we look higher mag, you can actually see that these little blobs here in the vitreous are similar, and that there's a little bit more of those sort of strands, if you can picture those in cross-section, also associated with the surface of this material. So we'll start at the front, save the best for last. So the histologic features of an indolent ulcer is that, first of all, that the epithelium is absent in an area, which it is at least right here. And then where present adjacent to it, that corneal epithelium is not adherent to the anterior corneal stroma. And also within that epithelium, there is loss of polarity. So what do we mean by that? That means that there's no longer a well-defined basal layer. And then also the cells often form these little whorls or eddies in the epithelium. So let's follow this a little bit and see if we can pick it up and see a normal basal layer where it becomes attached. It's a little bit attenuated here, but you can see that nice row of cuboidal basal cells that then go away over here. So that's a nice definition, a nice example of an indolent ulcer. Presumably they were treating this with various topical medications, but there are still a few little squiggly nuclei here in the corneal stroma, and those are neutrophils. So they're coming to help defend the cornea against infection. And not surprising, we also have a little bit of blood vessel growth from the limbus extending into that peripheral corneal stroma. Here's a beautiful example of a pre-iridal fibrovascular membrane causing peripheral anterior synechia. So this is the border, the anterior border of the iris here, and everything in front of it is that fibrovascular membrane. And it's causing the collapse of the ciliary cleft, so peripheral anterior synechia. There's a little bit of red blood cells around, both in the anterior chamber there and also in the ciliary cleft. So there's a little bit of intraocular hemorrhage. We have a similar story on the other side. So a nice epiphyseal pass. They said a closed iridocorneal angle of the other eye, and I don't think we were convinced that this globe had goniodysgenesis, so we're not quite sure how to explain that, but we'll get there, maybe, if I remember to come back to it. So there's some of those purple blobs in the vitreous, and let's just move on back to the main event, as Megan likes to say. So we have this sort of paucicellular somewhat, that means not super densely cellular material on the retinal surface. It has a lot of wispy basophilic material. and also some very bland spindle cells, some of which you can see the borders of pretty nicely, some of which are a little bit less well-defined. I don't think we saw mitotic figures in here. But there's really not much of a stroma to speak of. So there's not a cellular or collagenous stroma, which is something that we often expect with various types of neoplasia. So this is really sort of a loose conglomerate of cells in this sort of mucinous to basophilic material. When we look at the strands, they are basically similar material, just forming more sort of linear accumulations of similar things. They also do not have blood vessels associated with them. So this is, whatever this is an avascular proliferation of cells in the vitreous. Let's go look at one of those blobs in the up behind the lens. So kind of a similar story here. With some bland spindle to polygonal cells embedded in this sort of mucinous matrix, which is kind of weird, basically. And let's go back to the optic nerve and take another peek at there. What's going on there? So I mentioned that those cells, most of them are avascular, those accumulations of cells. But what we do have is this sort of loose collagenous matrix in front of the optic nerve head that does contain blood vessels. And also blood vessels extending from the central retinal surface into this sort of epiretinal vascularized membrane. So here's the inner limiting membrane of the retina here. And then we have this vascularized material and some similar spindle cells that are sort of mingling with the blood vessels. And then after a while, those blood vessels peter out. So we have this vascularization of the optic nerve head and the central retina. So this is kind of a weird case in general. Whenever we have sort of bland spindle cells in the vitreous of a dog, and then we also have vascularization of the optic nerve head and central retina, we think of canine ocular gliovascular syndrome, or COGS. So that is what we eventually settled on for this case. We did do a stain so the cells in this syndrome are glial-like cells. We don't know exactly what their origin is, but they do typically express glial fibrillary acidic protein, GFAP. So we did do an immunohistochemical stain for GFAP, which I'll show you right now. So the optic nerve should have a nice internal positive control because there are glial cells in the optic nerve. I think this is a little bit increased from what we would expect. So there's some glial activation in the optic nerve head. But when we move up into the globe and look at those cells of interest, you can see how darkly stained those are. So this is all a positive immunoreaction against GFAP. So these cells are expressing GFAP. So this is supportive of the diagnosis of the canine ocular gliovascular syndrome. This is, however, just an atypical case. They don't typically have the great amount of this sort of basophilic mucinous matrix that they did in this case. And they also more often are situated immediately behind the lens and not along the retinal surface. So this is a pretty atypical case. I think we should call this atypical COGS. There was also an indolent ulcer with that minimal neutrophilic keratitis, a preorbital fibrovascular membrane causing peripheral anterior synechia, and the optic nerve was a bit atrophied, and there weren't very many ganglion cells left. So this was a chronic secondary glaucoma as well. So COGS is about 50% of the cases of COGS that we have in the Coplow database are from Labrador retrievers, and 50%, the rest of them are from a wide range of breeds. This is a dog thing, not a cat thing, although we actually had a case this past summer, or last year sometime, that was a feline case that was very similar. But anyway, mostly this is a dog thing. We don't know the origin of these cells, but we presume that they are some sort of embryonal rest during development that sort of end up persisting in the vitreous, and then they slowly proliferate over time. They do not have blood vessels associated with them, and so they also are expressing vascular endothelial growth factor, or VEGF, and presumably that then goes along to initiate the vascular growth of the optic nerve head and the central retina. And oftentimes the cells undergo necrosis in the vitreous, presumably because of hypoxia, which then would increase the expression and secretion of VEGF. These are typically unilateral in a patient. I think we have a few cases where they're bilateral. Clinicians often will report an anterior vitreal opacity, and that kind of looks like popcorn. Sometimes they say that, at least we have interpreted their clinical images like that. And then often grossly, we'll see white material sitting right behind the lens. In this case, as I said, it was very atypical that it was mostly in the posterior vitreous. And let's hear what else. Oh yeah, and it is not associated with any sort of systemic conditions. So this is an eye-specific problem. It often leads to this neovascular glaucoma, so pif and pas formation and eventual glaucoma. Often there's also quite a bit of hemorrhage because those blood vessels that have been formed will be leaky, and they will leak blood into the vitreous. So there we go. That's all we have for rounds today. So I hope you enjoyed our unique cases, and that's all we have to say.
Yeah, we'll work on the recording here, and this session will be at our YouTube channel at some point, maybe this week or early next week. So you guys want to check it out, or just spread the word for people that were not able to make it. I